Hello, I'm Seth Martin from Johns Hopkins University. I'm a first-year cardiology fellow and happy to lead you through our poster here. This is titled Clinically Meaningful Underestimation of LDL Cholesterol by Friedewald at levels below 70, a study of 1.3 million adults. We actually calculated out that is 1 in 181 U.S. adults that we have in this database, so we labeled it the very large database of lipids, which ends up being the issue, VLDL. So, as we all know, LDL is the target of our guidelines, and it's calculated by the Friedewald equation, total cholesterol minus HDL minus triglycerides over 5, that being the estimation of VLDL cholesterol. So, it's previously been shown that there's some underestimation as cholesterol levels lower and triglycerides go up, and so the relevance of this problem is largely unknown in clinical practice, so we aim to test that. So we looked at estimated LDL cholesterol by Friedewald minus directly measured LDL cholesterol, so the bias in Friedewald compared to direct. And we used the VAP test for direct assessment of LDL cholesterol. These were patients who had testing between 2009 and 2011. We excluded those who had triglycerides 400 or above, so that took out 2% of the sample. We compared to NHANES to see is this population nationally represented, and we looked at adult treatment panel reclassification based on the guidelines. So our sample looked remarkably similar to NHANES, so we thought that they were fairly nationally representative sample. As LDL cholesterol lowered, we saw more underestimation. So anything below this line here is Friedewald estimation of LDL cholesterol being an underestimate. And this was especially the case in this group with LDL cholesterol less than 100 milligrams per deciliter, so the secondary prevention population. As triglycerides raised, we saw a skyrocketing in the magnitude of underestimation of Friedewald. And these are groups stratified by triglyceride groups. So for instance, this is the group of triglycerides of 150 to 199, and we start seeing a dense amount of patients. So this red is 4,096 patients in our population, and we start seeing a dense amount of patients in this group. So looking at the magnitude of underestimation, we see as triglycerides raise, there's more and more underestimation of LDL cholesterol. So we asked the question, well, if we directly measure LDL cholesterol, does that reclassify the patient based on adult treatment panel guideline categories? And there was indeed substantial reclassification. For instance, again, that group of 150 to 199 triglyceride level with an LDL cholesterol of less than 70, 39.1% of patients were reclassified. So these, because that's the lowest ATP category, those patients had to be reclassified upward. So meaning that these were patients who potentially were undertreated based on estimation of LDL cholesterol. So what we concluded is that there's frequently inaccuracy in LDL cholesterol estimation by Friedewald, and this is particularly the case where it's most crucial in levels in the modern secondary prevention range. And at those low LDL cholesterols and the high triglycerides, the magnitude of underestimation is often sufficient to lead to undertreatment based on the adult treatment panel guidelines. So at the end of the day, our results support replacement of Friedewald at LDL cholesterol with a direct atherogenic measure, such as non-HDL cholesterol or apolipoprotein B, particularly for patients who are targeting those secondary prevention cholesterol levels. It's been a pleasure. I hope you enjoy the poster.